Hi, everyone. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Andrea Bianchi, and I'll be the moderator for today's session. Our speakers today are Nipa Chauhan, Jessica Faust, and Rebecca Greenberg, and their seminar is entitled Pediatric Decision-Making in the Pandemic's Fourth Wave, Reconsidering Paternalism. Before I introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. The format of our seminar is a presentation by our speakers, followed by a facilitated discussion period. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now it is my pleasure to introduce today's speakers. Nipa Chauhan is a research associate in the bioethics department at Sinai Health. She works on issues related to women's and infants' health, fertility, and substitute decision-making. Nipa is also a part of the bioethics department at William Osler Health System, and she assists in teaching undergraduate and graduate bioethics courses at the University of Toronto. Nipa is a graduate of the Master of Health Sciences and Bioethics program from the Dalla Lana School of Public Health, and is also the founder and host of the popular bioethics literacy initiative, Cafe Bioethics. Jessica Faust is a clinical social worker in the neonatal intensive care unit at Sick Kids Hospital. In her role in the NICU, she supports parents and families with the challenges that often arise throughout an admission by providing tailored psychosocial care. She has a keen interest in increasing ethical awareness and building capacity to cope with ethically challenging situations, often unique to the neonatal population. She has also attended several trainings and conferences in the area of bioethics and completed the Harvard Clinical Bioethics course in 2019. She is also a member of the Bioethics Advisory Committee at Sick Kids Hospital. Jessica was awarded the Dr. Ted McNeil Award for Excellence in Clinical Social Work in 2021. And finally, Dr. Rebecca Greenberg is a senior bioethicist at Sinai Health. In this role, she leads the bioethics program and spends most of her time at Mount Sinai Hospital. Previously, Rebecca was a bioethicist at the Hospital for Sick Children. She is an assistant professor in the Department of Pediatrics and a core member of the Joint Centre for Bioethics at the University of Toronto. Rebecca has a Bachelor of Arts in Psychology from the University of Manitoba and a Bachelor of Science in Nursing and a PhD in Bioethics from the University of Toronto. She has completed an ethics internship at Baycrest Centre and a postdoctoral fellowship in clinical and organizational ethics at the University of Toronto Joint Centre for Bioethics. Prior to working as a bioethicist, Rebecca worked as a nurse in the area of general medicine. Her main research interests include pediatric bioethics, ethics education, and moral distress. Right, you can take it away for your presentation.
Thanks so much, Andrea. So this is an exciting opportunity to be here and share some of our thoughts with you. Just as a bit of background about how this talk came to be, as was mentioned in the intros, I previously worked at Sick Kids, and in that role had the privilege of working with Jess and the NICU team there, where we received a lot of clinical ethics consultations pertaining to essentially the zone of medical expertise and the zone of parental discretion. And that theme has since carried over in my time at Sinai. So we've been thinking about this for a handful of years, and more recently took the opportunity to delve into the literature and give this clinical topic some further consideration with Nipa's assistance. So in our short time together, I hope that we will be able to share and explore some of our thoughts around shared decision-making in pediatrics, but recognizing that they may have broad implications across the age spectrum, as we know that shared decision-making is a construct that goes all the way through to end of life. We will discuss some ethical approaches around paternalism and hopefully provide some practical considerations for those working in a healthcare environment about how and when to employ what we will be calling as a working construct. And this term comes from the literature. It's not something that we constructed on our own, beneficent paternalism. Oops. Okay, so I think it's important to talk a little bit about the current context and why we thought Although we've been thinking about this for a handful of years, why now? And particularly in the construct of a pandemic, where we have seen major public health measures going on for, upwards of 2 years now, and that has caused some erosion of trust in authority due to the evolving nature of a pandemic, due to the learning curve, and due to changing guidance. The back and forth and all of that goes with it we've seen cause some skepticism around trust in leadership, and also perhaps a lower threshold for paternalistic approaches generally. So maybe this is an interesting time to call for this, but we may say that now more than ever, it is appropriate, as we know that there are lots of conversations happening around patients who are not expected to be in an ICU, including children. And as we see conversations around vaccines and other things come forward, where we wonder to what extent should we have more directiveness from our healthcare providers. Next slide, please. Additionally, now being in the middle of the fourth wave, we know that the pandemic has shifted towards that of an unvaccinated cohort, which predominantly affects children more than ever. And I think that children have now been in school, a handful of weeks, but there has been some uncertainty about what the significance would mean of having children return not only to school, but to other activities. So we may see a disproportionate burden on younger children until the vaccine becomes more eligible to children under 12. And in doing so, we may see substitute decision makers, most commonly parents in pediatrics, having to make decisions for children as their children fall ill, who were previously healthy and have not really had opportunity to think about what they would do in those kinds of situations. No one would ever really want to have to think about that before it happens. Those of us in bioethics might have those conversations, I joke, around the dinner table, but for most people, that's probably not commonplace. And perhaps if there is a need to triage in pediatrics, it doesn't look like that's going to be the case, but there have been conversations because of, we're just heading into flu season, perhaps again, needing to think about the role of substitute decision-making and correspondingly the role of paternalism with that. Next slide, please. So I've been using the term paternalism, and I think some people may think that the opposite to that is autonomy. So I just wanted to take just a couple minutes to talk a little bit about the construct of patient autonomy and what we say may be implied with that. And really to be clear that autonomy is about a competent, a capable person having the right to make decisions and the right to refuse decisions that are on the table. And at its core really is acting on one's values, beliefs, wishes, free from any coercive influences. But sometimes there's individuals who misinterpret the scope of autonomy in the healthcare environment and misinterpret it to think that it is the right to demand a treatment that has not been offered. Next. So with that, healthcare providers' autonomy, and how does that relate to what we just characterize as patient autonomy? I hear a lot when speaking with clinicians this extreme desire to respect patient autonomy, which of course is laudable. And sometimes out of fear, there's a concern about being what they may say is paternalistic, and they may see that in a pejorative way. And as a result, perhaps may pull back in some situations too much so, to the extent where maybe they're actually hindering one person's autonomy, a patient or a substitute decision maker's autonomy, because they have left them to make a decision that is heavily burdensome without recognizing that there's an inherent asymmetry of information, meaning that clinicians are trained in medical and health disciplines for a very long time. Patients and substitute decision makers bring their values to the table, but they don't have the ability to understand the medical piece to the same extent. So there is a role to have some kind of guidance. And always concerned about what will be the backlash, whether it is concerned about legal implications or injuring the therapeutic relationship, which is sacrosanct to looking after children for sure. Next slide. So just to be clear, patients can only refuse treatments that are offered. And when I talk to clinicians and clinical consults, it's also very helpful to be clear that if there's only one viable option that's on the table, we shouldn't be posing it as a question. Asking a parent, for example, if they don't want CPR when it's not appropriate, what are the implications to that? We can talk about that more. So we're going to make an argument to say that we do think the pendulum perhaps has swung too far, where we see clinicians in some sense stepping back from their role of expertise for a number of reasons, and that we have seen maybe a misunderstanding of what initially started to be family-centered care to push too far into what may now be considered family-directed care. So we do think this has gone too far. So we will make the argument as follows: that there has been an erosion of clinical expertise in healthcare, that shared decision-making is not a well understood concept. So I think many people would say, yes, we support shared decision-making, but how you actually operationalize it, there is room for more convergence, because I think people perhaps there isn't a consensus definition and people operationalize this quite differently. A mild form of paternalism we will propose is appropriate and is ethical. And again, we are using beneficent paternalism as a placeholder and based on the literature that exists today. And that a form of paternalism is actually not inconsistent with shared decision-making, especially if we recognize, as I just mentioned, this concept of asymmetric ability to weigh in on decisions, given different things that people bring to the table. And that perhaps a lack of actually claiming the role of an expert can cause harm to the patient and their best interests. So we will propose a new way forward. And just to say, just as a caution to say, this is not something we are proposing that is an always situation, that in every clinical encounter this is appropriate, and we will at the end wrap up by saying what are considerations for when and how you should employ beneficent paternalism. I think the purpose of this talk is really to turn our minds to thinking about things differently, and that the approach can be titrated as needed. So I will now turn it over to Nipa.
Thank you, Becky. So just to give you another outline of how we're going to walk you through this. So first, I'm going to review some concepts of paternalism with you, and then I'm going to review some literature. Then we'll operationalize some appropriate paternalism, giving you tips for that. And then Jess will review some cases, and hopefully we have some time for discussion at the end. So I just want to start by explaining why we use the NICU as an illustrative example. So we feel that it's an example, it's a context in which the Ontario Healthcare Consent Act can really be explored. And the reason for that is because communication regarding the patient's treatment is exclusively done with the substitute decision makers and not with the patient. This is a context in which the team, the physician, the proposal goes directly to the substitute decision makers and not to the patient. And in the NICU, the patient has no established wishes, values, and beliefs. So the decision making that needs to incorporate those wishes, values, and beliefs, that's exclusively relied upon by the substitute decision makers. It's only upon the substitute decision makers' wishes, values, and beliefs that consent and decisions are made. So that best interest is on the SDMs and the clinical team, and the burden of responsibility also lies on those two stakeholders. Again, it's a great illustrative example of how we use the Ontario Healthcare Consent Act. So I do want to walk you through some things I found, position statements from the Canadian Pediatric Society. So this is from Counseling and Management for Anticipated Extremely Preterm Birth. And I'll just pull a quote from here just to show you some context. So the parents' expectations regarding their own role in decision-making can never be assumed. Some parents are reluctant to carry the burden of decision-making, while others want to be involved but do not know how. So what this quote actually illustrates is that we can't assume exactly what the parents are thinking, what they want to do. And it is possible that there's this dichotomy where some parents might not want to be involved in decision-making as much as others. And the zone of parental discretion is not as all-encompassing as we think. So we're going to expand on this a little bit more. But there are times when rooting down in clinical expertise is desirable. Another quote from the same position statement can shed some light on shared decision-making. Now, I know the acronyms here can get a bit confusing, but I'll try to say substitute decision-making and then shared decision-making. So shared decision-making is the best approach for preference-sensitive decisions. I'm just going to hop over to the yellow. So shared decision-making can mitigate parental grief around end-of-life decisions, enhance knowledge of and satisfaction with care, aid decision-making that is consistent with parental values, and foster collaboration with medical teams. So shared decision-making sounds great. It can do so much for both the team and for the stakeholders involved. Now, let's talk about what it should be. So it's a complex intervention in which patients and clinicians make decisions together as partners using the best available evidence. So it should be a shared responsibility, but the responsibility comes from different domains. So the physicians bring the clinical expertise to the table, and the substitute decision makers bring the values and goals to the table. Now, what we've noticed, what exists in the literature as well, is that current shared decision-making doesn't recognize that asymmetry of info. So as of now, it asks patients to act like doctors, evaluating highly technical data, and it asks doctors to act like a friend and not as a neutral agent. And this kind of situation that doesn't recognize the asymmetry of info places an unfair burden on substitute decision makers and on physicians and on the team, so all the stakeholders involved. So our solution is paternalism, but we want to make sure that we acknowledge, again, no one wants to be this physician. We're not advocating for a really condescending, oppressive physician or a condescending teams. We realize that the term paternalism is now synonymous with these pejoratives, and we don't want to go on without acknowledging that. But we do think there is a way to separate the good from the bad. So if we take a step back and pull some good, useful skills from the philosophical concept of paternalism, then maybe we could gain something here. So first, let's just try to define paternalism. So from the Oxford Dictionary, it's the policy or practice on the part of people in positions of authority of restricting the freedom and responsibilities of those subordinate to them in the subordinate's supposed best interest. So there are some key words here that are very familiar for those of us in ethics, like positions of authority and best interest. Now let's tease that out a little bit more. So we're going to break down paternalism. There's many, many different forms of paternalism, just as there's many different forms of autonomy. So I want to go through some different types and the ones that we would advocate for and the ones that we wouldn't. So the one that we would advocate for is beneficent paternalism. So this situation is one in which it's justifiable to limit choices if it results in an outcome the individual would value anyway. So this is a situation where, let's say there are some tests being done for the neonates and we need the results of those tests for decision making, and we can assume that the parents or the substitute decision makers would want the test to be done anyway. This is something that they would value anyway. Now, strong paternalism is something that we wouldn't advocate for. So this is a situation in which it would be justifiable to limit choices because the individual has mistaken, confused, or irrational beliefs. So of course, this is a little bit more synonymous with that condescending pejorative. And so what we see the difference as, it's in considering the substitute decision maker's wishes and balancing them with clinical expertise, rather than dismissing their values altogether. So the person that is going to be on the other end of paternalism is still, of course, being valued. We're not going to be dismissing their values altogether. So it might be tempting to say, what if we just avoid paternalism altogether? We don't want this term associated with us at all. We don't want to even be adjacent. So that is tempting. I totally agree. But I also want to share with you what some harms are of going in the other direction, of excess choice. And like Becky mentioned earlier, this might be seen as family-directed care. So what are some of the harms there? So there's harm to substitute decision makers and neonates in deference to substitute decision maker requests. So if it's being directed from them, there's some harm there. And placing clinical decisions on substitute decision makers that don't have that expertise is harmful. And not rooting down in clinical expertise, especially in situations around futility, can be very harmful as well. So what we hope to achieve in certain situations is we hope to let the balance settle somewhere in the middle between excess choice and excess paternalism in a way to further reduce harm for all stakeholders involved. As you know, there might be situations where sometimes a substitute decision maker requests a clinically inappropriate treatment outside the clear standard of care. So when that happens, what are we supposed to do? We're hoping beneficent paternalism is the correct middle ground to go towards. It means it's rooting down in clinical expertise, in some cases, results in the outcome with the least harm done. So now I'm going to go into some of the literature that backs this up. Now, it is a little bit dense and there's a lot of it, so buckle your seatbelts. Hopefully we can get through this in a timely manner. But I'll just get started with an article here from the CMAJ. So this is referring back to fall of 2019. This is when CPR and DNR protocol was being debated upon, and there were some edits, revisions to policy. So the title of this article is, "Do Physicians Require Consent to Withhold CPR that they determine to be non-beneficial?" Traditionally, this was talked about in more of an ICU setting, but we want to make sure that it's realized that this applies to the NICU as well. So to give some context, some key points, the Ontario Superior Court of Justice said that physicians do not require consent to withhold cardiopulmonary resuscitation that they believe to be medically inappropriate. And physicians still have a professional responsibility to communicate or make reasonable efforts to communicate the limitations of CPR. So key word here that you'll hear again in our presentation is the responsibility to communicate. We do feel that this is very important to remember. And I'll just move on to another article here. So this one is talking about dysthynasia. So I'll define that for you in a little bit. But the context is for attempting CPR in terminally ill children. And this article it's really fantastic. It goes through some lessons learned in CPR or DNR contexts and can provide insight into end-of-life scenarios and withholding or withdrawing discussions in general. Now, what is dysthynasia? So this is the exaggerated prolongation of agony, suffering, and death of the patient. And this is when the authors actually say that when treatment is highly unlikely to achieve the therapeutic goal, we should not burden parents with decision to forego treatment. So this is getting into that beneficent paternalism territory. And it's actually a moral thing to do to shift moral responsibility to physicians and encourage a model of informed assent. And so when shifting from informed consent to informed assent, the process requires deep emotional intelligence and collaboration from the entire team for success. So you'll see a common theme in the literature and also in our presentation is that we don't advocate for unilateral decision-making from the physician. Just to be completely paternalistic, we're not advocating for that. We're saying that collaboration from the entire team and some deep emotional intelligence and really picking up on cues from the patients and or substitute decision makers in broader contexts is very, very key here. So important for practice, here's one of our first tips. It's important to establish early on that physicians may make decisive decisions based on clinical expertise, and that substitute decision makers will be enlisted to either choose between those informed recommendations or assent to one recommendation. So this is something that the authors suggest that might make decision-making in a difficult context like dysthynasia to be a little bit easier and more compassionate. So dysthynasia, just to touch on it again, it actually makes rooting down in clinical expertise much more required, and therefore makes beneficent paternalism much more appropriate. So to touch back on something that Becky said earlier, it's important in situations like this to see if it's appropriate to not pose a question, to not give a question to already really distressed parents and distressed substitute decision makers if there's only one viable answer. So another article that we came across is from Dr. Lizotte et al., and it's entitled Techniques to Communicate Better with Parents During End-of-Life Scenarios and Neonatology. So overall, what it's talking about is it gives tips on how to communicate during an end-of-life scenario in the NICU. And this is according to the substitute decision makers, according to the parents themselves. They were all interviewed. And so I pulled this graph, this chart from the paper that I found to be really enlightening. I found there were some really interesting examples here of beneficent paternalism that was actually advocated for by the parents. So I'll just walk you through what these columns are. So on the far left there, it's positive interactions with parents during the resuscitation. So these are examples of positive interactions. And then in the middle column there, these are examples of behaviors to adopt. And then on the far right column, it's examples of behaviors to avoid. So you'll see that I highlighted at the bottom there that a positive interaction that parents thought is one in which they're not asked for permission to stop resuscitation. So here's a quote from one of the parents. They said that it was clear they had done all they could, and she said it was time to stop. So they're referring to the physician there that might have been trying to resuscitate the neonate. And it was the physician that thought this was a good time to stop. And she said they had done all that they could. And this was perceived to be a positive interaction, a behavior to adopt. This was seen to be a good thing by parents. And something that was seen to be a bad thing by parents was being asked the question, do you think it is a good time to stop? So they ask, really? He asked the parents if he should stop. So there was some disbelief there that they could even be asked something like that in such a stressful situation. So I see this as a perfect example of beneficent paternalism. In this situation, do not ask for parents' permission to stop resuscitation. It seems that this was seen to be really positive by parents. And so it's all nice to just say that, but it's really important to figure out when might substitute decision makers want to defer decision making. So it might be in a resuscitation context, but in which other context? Let's give ourselves some clues here. So there's this paper from Dr. Weiss et al., and the title is Parental Decision-Making Preferences in Neonatal Intensive Care. And it goes through how we might know when it's more or less appropriate to practice beneficent paternalism. So I pulled this axis out of the paper, and I found it to be really informative. And I've just refined it a little bit more to pull out some things that that might be useful for us in terms of context. And so you'll notice that the further left you go on this axis, this is a situation, or these are situations where parents are more likely to want to defer decision making. So these are situations where there's high urgency, for example, where maternal betamethasone injections need to happen or intubation needs to happen. If there's medical expertise, a high degree of medical expertise that's required, again, like intubation, resuscitation, touching back on that last article. And then the further right we go on this axis, you can see that these are situations where parents might want to keep decision-making capacity. So, for example, if they're already parents, they already have another child, they're very familiar with this role. If there's high risk involved, but not necessarily high urgency or medical expertise. And the parental role is really important here in terms of dietary choices. This is something, again, that they're used to if they already have another child or they feel that the dietary choices and nutrition is within their expertise. And if foreign bodily fluids are involved, so something like a blood transfusion or breast milk is involved, parents might want to keep decision-making. And so moving on to another article, this one I found to be really informative. It actually really touches on beneficent paternalism itself. So this is called The Moral Experience of Parents Regarding Life Support Decisions for Their Critically Ill Children. It's a preliminary study in France. And this touches on how removing choice might be a good thing, and it investigates why parents in France might appreciate paternalism in the NICU. And so here's a quote that you might find informative. So I'll just read through it for you. The common pediatric critical care practice in France is for physicians, rather than parents, to maintain the ultimate responsibility for life support decisions in children. Some French literature asserts that it is inappropriate for parents to bear such responsibilities because they do not have the required knowledge and should be protected from feeling culpable for such decisions. And so this kind of touches on the line between beneficent and non-beneficent paternalism, or strong paternalism, if you remember. So again, we're talking about communication, like I mentioned earlier. So this quote from that same article I found to be really important. It says, the experiences reported by these parents reveal medical paternalistic practices without meaningful conveyance of information. Consequently, this was experienced as a non-beneficent paternalism. In fact, it was experienced as emotionally harmful and offensive. So the key distinction we like to make between beneficent and non-beneficent paternalism is that in beneficent paternalism, of course, information flow between stakeholders is still required for informed assent. And another study from some of the similar authors, it's called Parental Involvement in Treatment Decisions Regarding Their Critically Ill Child, a comparative study of France and Quebec. So now we're getting a little bit more into Canadian territory here. And so it asks again, why do parents in France appreciate paternalism in the NICU, and how does this compare to Quebec? So this actually specifically talks about beneficent paternalism. So I'll read this quote for you. Although the French have tended to espouse a model of physician paternalism, i.e. physician as decisional authority, several parents, physicians, and nurses in Quebec also reported physician-directed treatment decisions. In all cases, this was described by physicians and nurses as beneficent paternalism, taking the responsibility for difficult decisions in order to do good. For example, to protect parents from feeling culpable and ensure the right decision is made for the child. So here's one more article. It's called Tell Parents the Truth, but Tell It Slant. This one I highly recommend just reading on its own. It has tons of nuance and it's very, very fascinating. But some of the things we pulled from this article we found to be really relevant here for this beneficent paternalism conversation. So the author, Lantos, urges neonatologists to learn to tolerate the discomfort within ambiguity. So like I said, nuance, tons of ambiguity. And so explicit decision-making, or quote unquote affirmative agreement, is sometimes too painful. Saying like a clear yes or a clear no to certain treatment decisions can be really painful. For substitute decision makers who display subtle signs of internal conflict, perhaps an informed assent approach is more humane. So here, another author is talking about informed assent and how it might be maybe the more moral thing to do. Here's a quote from the article. So Lantos says, we should conclude that the parents oppose decisions to limit medical interventions, or instead, conclude that parents oppose a decision-making process that forces them to be accountable for a decision that violates their deepest emotional needs. So very, very powerful. And the point here is not actually to display medical authority and be that finger-wagging doctor, but to actually use clinical expertise as a means of diffusing responsibility. So the parents or the substitute decision makers don't feel it's all on them and they're making one of the most difficult decisions of their lives. And so like we mentioned earlier, beneficent paternalism does require deep emotional intelligence that picks up on nonverbal cues. And to continue with that, in reference to accepting a parent's non-dissent as sufficient, the article concludes not soliciting that agreement leads to better care of the patient, better psychological well-being for the family, less conflict, and less moral distress. And here we're touching on tragic choices. So there are situations in which people clearly want something, but also, and equally passionately, do not want to take individual moral responsibility for the decision. So Lantos is advocating for tragic choices to be diffused among, first of all, the substitute decision makers, but also the clinical team involved as well. So doctors, and we put an asterisk there because it's not just about doctors, but rather the whole team. Team approach is key. So the team needs to listen carefully to understand what parents are saying, what they are not saying, what they mean, and what they need. Sometimes they may be saying that there are things that they prefer not to discuss or decisions that they prefer not to affirm. But finally, we're going to get to actually operationalizing paternalism. And we call it 2.0 because this is the new paternalism. It's beneficent paternalism. So what to do? We have some ways to operationalize beneficent paternalism for the whole clinical team, but also for the most responsible physician. So for the team, we say to remap expectations and reshape hope. We're going to expand on that in a second. And the second, for the most responsible physician, we say that it's important for the MRP to give a treatment proposal and not ask for direction. So what do we mean by remapping expectations and reshaping hope? So what we're hoping the clinical team can do is help the substitute decision makers actually shift from determining what treatments the patients or the substitute decision makers want, and actually shift that to what they hope treatment will accomplish. So this kind of language about remapping and regoaling, we got from this really, really helpful article from Dr. Carter. And I just want to share another quote from this article. So in cases already impacted by the urgency of premature labor, for whatever reason, the dream may be simply that the baby responds favorably to resuscitation and live until discharge to go home as healthy as possible. So, you might hear in these kinds of situations the parent saying, do everything for my child. But we need to understand what they mean and what they're expecting everything will accomplish for their child. So again, it's important to try to map what expectations the SDMs had and help them remap their goals to the clinical reality. And the full clinical team can help here. So they can aid in this transition and they can help reshape hope and optimism. And this skill avoids perpetuating false hope and can accommodate different cultural perspectives. So in certain situations, saying like, yes, we're going to do everything might give some false hope to those substitute decision makers and make them feel that everything can be done and they're going to walk away with the child that they'd always dreamed of. But we just want to make sure we're reshaping that hope and figuring out what's actually possible clinically. Now, for the most responsible physician, like we said, give a treatment proposal and don't ask for direction. So rooting down in clinical expertise actually allows for cohesive and informed treatment proposals that accommodate remapped expectations. So just to visualize it here, the MD should be giving that proposal to the substitute decision makers and not be receiving direction from the substitute decision makers. But what we're hoping this can accomplish is that the direction of treatment proposals comes from the MRP. And this actually limits the substitute decision makers' choices to what is clinically reasonable. Now, one of the last articles I'll touch on just kind of wraps it all up. So the title is End-of-Life Decisions for Fragile Neonates, Navigating Between Opinion and Evidence-Based Medicine. And here's a quote. So, is giving recommendations a bad thing? The pendulum has shifted abruptly from paternalism to informed consent, where physicians often hesitate to give recommendations. Some parents may prefer honest recommendations with the understanding that their voice would be heard and choices respected. The physician treatment proposals can deeply reduce harm and harm experienced by parents of neonates who feel profound feelings of guilt and grief. So now I'm going to hand it over to my colleague Jess, and she's going to go through some case examples for you.
Thank you for that. So really the hope of the case examples is to really provide a clinical lens of kind of tying this all together. And so we've seen lots of cases here in our NICU, which we've kind of talked about why that might be a good example for beneficent paternalism. And so I'll just walk you through this one first, which is a neonatal case. But we had twin girls born at 32 weeks gestation. And mom herself was in the medical field, actually from the Middle East, but was here for a medical conference when she delivered these babies early. And the babies were diagnosed with a genetic disorder that would have been associated with severe disabilities. Mom was of a Muslim faith, and she expressed real concerns about quality of life for the babies and the impact on the family, especially with regards to their geographical location, because they would be going back to the Middle East. That was the plan, because mom was here unexpectedly delivered, and dad was back home. And so in this case, what happened was that mom actually requested that maternal uncle be the designated decision maker. And so just in terms of some of the discussion so far around sometimes the burden that substitute decision makers feel, the kind of conflicts that one might feel having to make choices around the outcome or around kind of the different pathways available to them for what the future might look like for their babies is just extremely burdensome. And so mom came to the medical team and requested that her brother be the one to ultimately be the decision maker, though she was well informed. If you can go to the next point. So if you go to the next slide, we talk a little bit about understanding the case. So mom early on shared views on quality of life and what she saw that to be, what she was hoping for, and her kind of changing hope for her babies. Mom requested the uncle to be really involved early on in the care, especially in light of dad's absence and him being back in their home country. And though it was important for mom to remain involved, she was really clear about what role she was comfortable with. She was okay to be present and to hear the information and to hear what options were available. But in terms of that actual sanctioning of what the decision was going to be in terms of how to move forward with medical care, she wanted that to be for her brother. So, the physicians reviewed the prognosis and what this might mean for them as a family in terms of the medical diagnosis and recognizing families' values and hopes. And they did propose comfort care as the recommended option. So in this case, there were multiple options that could have been the recommended kind of pathway, but for what they thought was in this baby's best interest based on the medical condition and what mom had shared, they recommended palliative care for the babies. And so with mom present, maternal uncle was the one to provide his agreement with that plan and move forward with comfort care. So I just thought this was a good example about how beneficent paternalism can be situated within a shared decision-making context. It kind of highlighted the importance of the medical team coming with a recommendation. And so that arrow that Nipa showed earlier, that it should be the MD that comes with the medical recommendation to the family and not the other way around. But the arrow kind of went the other way in terms of having received already parental kind of values and hopes and expectations for the baby. So it's not that they hadn't received any of that. It was with all of that in mind that proposal was made. I think just a point also to know that, we try to stay away from things like asking about timing or in terms of asking parents, when would you want to proceed down this pathway? We try to work backwards and kind of figure out what's important to you to do, knowing that this is kind of the pathway we're on. How can we support that, but not necessarily ask parents questions like, when do you want this to happen? Recognizing that, as Nipa talked about in that article from Lantos, that these are tragic choices and that's just not something that is fair to kind of ask a family, but kind of getting their consent along the way around if the plan is kind of feeling like something they're comfortable with. So you can move to the next one. So in case 2, we're going to talk about how this might apply in a adult setting. So if we have an 85-year-old woman who's quite frail with a history of dementia and diabetes coming to the emergency department for respiratory decompensation, from a nursing home resulting from COVID-19. So again, more of a current context. She's been estranged from her family, but her adult daughter is the legal decision maker. There's no advance directive, so there's not a lot of certainty around what she would want. But the social worker shares with the team that the daughter, who's, like I said, the SDM, is experiencing deep feelings of guilt for not having visited with her mother in months. So this patient decompensates, and this becomes an ICU admission, and the patient, the 85-year-old woman, is on the ventilator, and the physician approaches the daughter with a no CPR order. So saying something like this: given the totality of your mom's condition, should her heart stop, the team would not resuscitate her, as it is not felt that this would be successful and in her best interest. So I just wanted to have an illustrative example of some of the things that NIPA had talked about in terms of proposing the treatment plan. And if you can go to the next slide. So I think just in terms of that silence and ambiguity, my cautionary tale is that oftentimes when physicians are in these positions and when we kind of go in as a team and talk to families, that silence can be really uncomfortable, kind of following what would be this recommendation, which would be not to provide CPR. And so sometimes we're tempted to say things like, is that okay? To ensure that the family understands, or the substitute decision maker understands what's been said. And so I guess I would just encourage to try to take a step back from that and think about what are we really asking families that we've recognized are faced with these tragic choices, and what might be some of the harm and some of the benefit of posing a question like, is that okay? What might be gained and what might be lost? And so we talked early on about excess choice and about posing questions and about maybe the idea of more of an assent approach rather than needing kind of affirmation verbally about kind of understanding. So I think we need to think about who benefits when we ask questions like that in these kind of really difficult situations, recognizing that these are really difficult circumstances that families are finding themselves in. And it might not be the kind thing to do to ask them to, explicitly agree to something. I know NIPA talked about emotional intelligence. We do need to look at families' body language. We need to provide pause so that they can come back to us with what they're thinking. And so those moments are really important. And so upon some reflection of clinical work with families in the NICU, so things to think about are parents, usually that's my case, or SDMs, avoiding a certain way of talking about plans for their loved one's future. Are they telling us in subtle ways, and maybe sometimes not so subtle ways, that they do not want to be made accountable for decisions to withhold or withdraw life-sustaining treatment? Are they telling us that they oppose a decision-making process, which I think NIPA highlighted early on, that forces them to be accountable for a decision that violates their identity as what a good parent or good loved one would do? And always kind of coming back to, what is our relationship like with this family? Do we have a good sense of their hopes and goals and values? Do we need to spend time understanding that better? Because I think that's really important and central to everything that we're doing. And I don't think that necessarily means you have to have had a lot of time with the family. So I just want to make that distinction. So some key messages and takeaways for practice, I think, paternalism in its truest form is not a good thing, but it might be a bad word, but conceptually an important thing to consider. And that the relationship is really key. It's of utmost importance. We need to know what a family's thinking. We need to know what they believe in, what their values and goals are. This idea of nonverbal cues is really important. What are families telling us? What are they not saying? And, continuity and consistency of care can always help. It's essential for the interdisciplinary team and the subspecialty services to have a consistent approach so that we all have all the information about previous conversations. Getting comfortable with silence and ambiguity is gonna help, doing less talking and more listening. And I do think it's essential for the medical team to make a recommendation. It's not always possible, but more times than not it is. And I think it does support families in kind of moving forward and feeling unburdened as much as they can about what that path looks like.
So I'm going to do something I don't normally do, which is sort of cut us a little bit short. We only have 2 slides to go, but we started close to 10 minutes late with technological difficulties. And essentially, just to maybe orient you to this, so we have a time for a couple of questions. Happy to stay a few minutes late. You know, when I started, we had that caution sign to say this is really a question of exploring beneficent paternalism and to titrate it accordingly. And this is really just a pictorial representation of our thoughts to say when is more or less of a paternalistic approach called for. So we can leave that up for questions. And you know, I think that the wrap up slide we could just forgo for now, just because I know we're almost at the hour mark. So maybe we will pause here and open it up to you guys.
Thanks so much for this incredible presentation. And so we did certainly have comments and questions that came in. The first of which is a comment, but I think there's a bit of a question embedded within it, or perhaps your response would be appreciated. This is from Roxanne saying, thanks for the excellent presentation. I still take issue with using paternalism. The reference to the all-knowing male clinician is problematic, so shouldn't be propagated in my opinion. Additionally, paternalism denotes a negative opposite to autonomy. Adding beneficent doesn't take away the negative. I suggest a term like titrated directiveness and counseling fits better. So perhaps just your thoughts on that.
Thank you, Roxanne. So nice to, we can't see you, but to know that you're on right now. So that's awesome. And I think you've made an excellent point, and a point that we've heard from others. And I love your suggestion. And that's why we said this is sort of a working construct, but I think you've done a really nice job of articulating some of the downfalls of this antiquated word and the historical association. So thank you. We'll definitely take that forward and follow up with you.
Okay, and a couple of more came in. So one has to do with, and this is an anonymous question, just about values perhaps unknowingly influencing clinicians to put forward some options instead of others. And so this person notes, just, you know, in some contexts around the world, there's a specific anti-disability bias that exists, and perhaps particularly at times in the NICU. And there could be, and just recognizing there could be limitations in clinicians' abilities to interpret the medical literature. And they can sometimes assume a family's inability as well to care for a disabled child based on factors like socioeconomic status or divergence from the nuclear family. So I guess just a question around whether or how we may respond to potential biases of clinicians seeping into this beneficent paternalistic perspective.
I'm happy to speak to that a little bit, because I think that question definitely resonates with me. And I think we didn't talk about this here, but I've been spending a lot of time thinking about the IPO framework, where you think about, you know, what's impermissible, what's obligatory, and what's permissible. And so I think there are times where all permissible options are on the table, but there's still a recommendation made. And it should be with, you know, the idea of what the family is hoping for, what they're valuing, what it is that, you know, what is the outcome, like Nipa talked about in some of her slides. Let's look at what it is that they're hoping for at the end of this. But I think bias is definitely, you know, prevalent in the work that we're doing, and it's something we always need to be mindful of. And so having a lot of exploratory conversations with families and having that relationship is really important. I don't know if others have something to add.
I would echo what you've said and just add to, so referencing the chart in front of us, you know, number one here in green, that the patient values and wishes are known. I know there was the comment that maybe they're not aware of their own bias, but I think this is sort of an opportunity to check, you know, whose wishes and values is guiding the decision. And also when we look at some of the medical considerations, trying to get a sense of, you know, what would most people do from a professional medical perspective, not so much letting values creep in, recognizing, as was mentioned, there are places in the world where as a society, everything is sort of skewed and biases, but hopefully looking at some of the things to say, okay, what are we going to check? What can we use to check ourselves? This is not me as the N of one clinician, but there is a sort of medical consensus and also very clear direction of what would happen if we didn't do it. But very important to know what are the possible pitfalls of this approach. And so both Roxanne's comment about language and this comment we've just been talking about is most helpful. Thank you.
Thanks. And do you want to just take what, I know we're over time, but we did start a little bit late. Perhaps just one more comment / question. Is that okay? Yeah, okay, for the presenters, okay. So
Sure.
This comes from Jane. So there's 2 comments from Jane, but the first of which just says, I'm not understanding how physicians proposing limited treatment is incompatible with informed consent.
Can you just say, the question is, I'm not sure how a physician proposing limited treatment is incompatible.
Yeah, I'm not understanding how physicians proposing limited treatment is incompatible with informed consent. And so I guess there's that idea there that perhaps what you're proposing is that the limited treatment options are somehow, or proposing them is incompatible with informed consent, but perhaps that's also not what you were saying. I think it's just a clarification here.
Mm-hmm. I would agree with the comment. I don't think that is what we're saying. I'm uncertain where the point of confusion was. But I think it is when there are a number of defensible, appropriate options on the table, they should be presented equally. And so it doesn't mean that there's only one option. It's, I think, more appropriate to use paternalism when it is clear. So here's an example how the medical certainty piece, again, looking at this pictorial representation, is very, very important. So, usually when you have high medical certainty, you really only have usually one option kind of floats to the top. But in a situation where you would have lower certainty and therefore a number of options rising that are palatable, then less role for paternalism. So I think we would agree with the comment for sure.
Yeah, thank you so much.
And the recognition that informed consent should be part of everything that we're doing. I think the distinction maybe was around needing a family to say something verbally rather than kind of a recognition of understanding and agreement in other ways.
Thank you so much. And so it is time. I recognize it's 5:04. Thanks to everyone for staying on a few moments late to get through some questions. Thank you to our speakers, but I'll certainly thank you again. And so our next seminar will be on Wednesday, October the 13th, where Bryn MacArthur, myself, and Alexandra Campbell will be discussing illicit substance use in physical rehabilitation settings. And just a note to everyone who's tuned in here that to sign up to receive our weekly seminar reminder emails, please feel free to email jcb.info@utoronto.ca. And CSB students enrolled in the CSB seminar course, please just remember to keep track of your attendance. And thank you to Nipa, Jessica, and Becky on behalf of all of us for this thought-provoking presentation. We appreciate it.
Thank you.
Thank you. Good evening.